We've got to wait about 2 minutes before the YouTube goes live. So if anyone wants to start the sing along or something. So you can heckle.
So I can heckle.
Yeah.
I'll wait till the YouTube starts.
Yeah. Hi, good afternoon, and welcome to Annecy. I'm David Sinclair from the International Longevity Centre, and for those of you who don't know ILC, ILC UK, we're one of 16. There are 16 ILCs across the world, and this year ILC UK is celebrating our 25th anniversary, and I've just written a blog about it, so I'd encourage you to have a look at how the world has changed in this space. But interestingly, 25 years ago, Bill Clinton only sent 2 emails whilst he was in the White House, whereas Al Gore had a PC, apparently. Of course, we couldn't have organised this today without the technology, and the fact that we're able to stream this across the world at the same time feels astonishing, although clearly 25 years is not a long time. It doesn't feel like a long time to me at all. But thanks again. It's great to be among friends here. We have friends from some of our partner organisations like CLCI, FIP, IFA, Johns Hopkins joining us through the week, and we're also very grateful for all of our funders, the funders that have made this event possible. And let me give them a quick mention. In terms of the prevention programme, we have Amgen, Home Instead, Gilead, GSK, MSD, Pfizer, Seqirus and Sanofi. And I think one thing that's worth saying is sort of just very briefly is, of course, one of the biggest, and I mentioned this at our last launch, one of the biggest challenges of doing multi-funded pharmaceutical work is that you end up with spending quite a lot of time arguing, well, not arguing, with 6 different versions of the declaration that says this is independent work that won't, that, you know, this is grant funded and you therefore have no influence. And the lawyers are very, very firm that their version is the right version, but they're all slightly different. In terms of the next couple of days, I'm going to be very, very brief. I'll try to be brief. We're going to kick off with a bit of framing from my colleague Sophia, and we've been doing some really interesting work with the support of Sanofi over the last year, last couple of years really, which has really been exploring and trying to make the case that investing in health is not an economic cost, but can actually contribute to economic prosperity. So, and to sort of slightly summarise Sophia's work in a very, very short way, essentially investing in prevention, investing in vaccination, investing in health means that broadly people work longer, they spend more money, they volunteer more, and they care more. So there is absolutely a really strong economic link between prevention and economic success. We're going to talk then a bit about the lessons from COVID, and we've got a brilliant panel of people joining us. And I'm not going to run through it in a huge amount of detail. I think one thing's worth just touching on at the beginning, though, is actually I think in the last few years, the work we've done in this space, we have had, we would argue, we've had huge amounts of impact. We've engaged with ministers from across the world. When we did an event in Japan alongside the G20, and we had 5 ministers joining us. We've had since then, in virtually 4 or 5 ministers joining us through webinars as part of this programme. So we've had really, really strong engagement. And actually, for example, with the Japan G20 event, we know that following the event, the communique was changed. So we actually think we had a degree of influence as well. We have directly worked with hundreds of organisations over the last sort of the last few years, and reached sort of policymakers in events through events and direct contact globally. So I think we had, and Kate's going to talk a little bit more about that influence. We're having a barbecue later, and for those of you watching in the UK, I'd like to assure this won't be like a UK barbecue, because firstly it's not raining, and the food probably won't be burnt. So you know, we'll escape from British tradition from that point of view. Tomorrow we're going to look globally at, and we've got great to have David Salisbury here to chair the sessions on adult immunisation, look at Japan, Hong Kong, France, do some country profiles to sort of look at what's been happening over the last few years. We have Lois, really glad to have Lois from Johns Hopkins to talk about some of the global work she's been doing. We're going to be talking, then moving on to looking at issues around uptake amongst adults, so whether that be in deprived communities. We've got GSK talking about healthcare professionals, the role of social media. We've done this fascinating report against a piece of work that Sophia will talk about tomorrow about the engagement of individuals through social media. And also in terms of reaching the hard to reach. And we have FIP joining us remotely. We've got a session on advocacy with Jane from IFA, Gonzalo from FIP, and Jean-Pierre joining us. Then lunchtime, and I should say the plan is to have a photo, and for those of you who've been to Annecy before, these sorts of events, there are only 30 of us here, and we only have 65 minutes for lunch and the photo. And my experience of the photos at these sort of events is they can easily take 2 hours. So we will be relying on Lindsay to get us in a line at exactly the right moment, so we don't spend 2 hours trying to take a photo with everyone looking the right way. We're going to be talking in the afternoon about the prevention report and what we've got, and then the plans for next steps, as well as some really interesting work we've been doing with Sean and Amgen on adherence, which actually started off with a really interesting conversation about the fact that in all over the world as a result of COVID, you saw individuals. You saw governments providing all sorts of incentives to encourage people to have their COVID vaccine, and it wasn't entirely clear how many of them, firstly, how effective any of these were, but secondly, how effective they were in individual contexts. And I think there's a really interesting, the piece of work we did sort of went slightly broader than that, but I think there's still quite interesting work. And NICE recently in the UK said we need to do more work on adult vaccination in the UK to look at the issues around incentives, because actually does it really, would it encourage you to have a vaccine in Thailand if you were given a free elephant, or in some US states I think a raffle for a gun, or marijuana? We had all sorts of things, all sorts of incentives. We're planning to go for a walk then, although I've had some cynicism already from people around the likelihood of, firstly, us doing this, and secondly, our ability to get to Annecy and back. So we may not quite make it to Annecy, but the idea is that we go to quite a lot of these events and then never escape from these rooms. So just want us to have an opportunity to have a chat. And in the same way that English people love going for a walk, we also love a quiz. And one of the things that we're going to do over dinner tomorrow is have a quiz. And this is partly a desire for us to make sure you're listening during the day, but it's also an attempt of ours to try and engage and get conversation going on some of the issues that have emerged during the day. So it will hopefully work. We've done a few before where but there will be raffle prizes. That will scare the lawyers as well. But we will find ways of making it really, really fun. So I promise. And then finally, Wednesday morning, we've got a session where we're looking at the future and where we're going. And I just want to particularly flag, is Tilly? Do we have Tilly? I haven't seen Tilly. Oh, Tilly. I want to flag Tilly, who about 6 months ago, I sort of put a thing out on social media saying, is anyone 25 or under and is really interested in ageing? And Tilly was one of the people who replied. And given it's our 25th anniversary, what we wanted to do was sort of do a bit of a perspective for someone who is younger in terms of reflecting on the session, but also on what prevention in an ageing world might mean for all generations. So really, really glad to have you here, Tilly. Not putting pressure or anything on you. And then we've got Kate talking about next steps. Now, I've gone on too much. For me, key messages that I'm really keen for us to get out is that, as I said, there's a really strong economic case for prevention. And I hope that comes across. Secondly, that I think governments recognise this. The fact we got 5 or 6 ministers in G20 means that they get this, but they were health ministers. How I was talking to John earlier, and David earlier. How do we get the messages from health ministers into finance ministers? I think is a big part of the challenge. And then thirdly, actually, I think we've got a real good opportunity to change things. You know, actually, COVID has highlighted really significant opportunities to influence national and global health policy. And I've talking to colleagues recently about, for example, you know, the issues around uptake of, and indeed the COVID targets in places like Romania, parts of Central and Eastern Europe are pretty atrocious. And it strikes me that if we can't use COVID as a way of engaging really strong public health in parts of Central and Eastern Europe, then actually we never will manage it with anything else. So I think there is a real opportunity there. So I've gone on too long, and I'm going to pass on to my colleague Lindsay, who's going to tell us what we need to do. Is that right, Lindsay?
Hi, welcome. I'm Lindsay Gawley. I'm the head of operations at ILC. You will have had a barrage of emails from me over the last few weeks, so apologies for that. Just a quick kind of, it's mainly sort of housekeeping stuff, so it's boring but important. Firstly, we've got 6 remote speakers who are going to be joining us over the course of the 3 days. They've been unable to join us for diary because of diary constraints. Yeah, exactly. I don't like cheese. But we have invited them to join at any point. So not just for their session. We want them to feel like they can participate in the same way that you are able to participate. So if you are chairing a session and a face is there that you don't recognise as being somebody who's part of your session, please don't be put off by that. Please just treat them like you would any of the other delegates in the room. We are going to be live streaming, as David has already mentioned. There's about a 30-second delay, so for those who are watching the live stream, just be aware of that if you're following tweets and that sort of stuff as well. If I could ask everybody in the room, if you are asking any questions, please can you make sure you speak into the microphones? Otherwise, those who are watching the live stream won't be able to hear anything. And in terms of the microphones, you just need to hit the little button in the middle, the silver button in the middle. That will then activate the microphone, and then you hit it again in order for it to mute again. We are using Slido for questions, and as you can see, we've got the Slido login there and then the participants code. That's predominantly for those who are watching the live stream. Obviously, everybody in the room today, you can raise your hand, and we've got obviously the microphones on the tables, or if you're up here, then we've got handheld microphones. There aren't any fire drills scheduled for today, and I'll obviously find out about the next couple of days. So if the alarm does sound, please could you just follow the instructions of the staff at Les Pensières? That would be wonderful. If you feel the need to stretch your legs, please do. Just have a wander around at the back. But obviously, if you do want to ask any questions, you'll need to race down to the microphones again to ask your questions there. I'm likely to be kind of here and there and everywhere over the course of the 3 days. So if you do need anything, just grab me or grab any of my colleagues. We've all got the red lanyards on, so we'll be able to hopefully help you. If not, we can speak to the staff here. And I think that is everything from me. I hope you all have a wonderful time.
Thanks, Lindsay. I think if Boris Johnson appears behind, he's probably in the wrong meeting, by the way. Looking frazzled, perhaps, at the moment. No, thanks, Lindsay. Clearly, really keen to have sort of your engagement throughout the session. Today, tomorrow, and Wednesday. Let me now pass on to my colleague Kate, who is joining us from London. If we can make the tech work. Yep, great.
Hi there. Hello. Hopefully that's working. Great. Had a yay. Good afternoon, everyone. My name's Kate, and I'm the head of projects at ILC. I promise I do like cheese. That's not the reason that I'm not there. So I'm sort of heavily pregnant at the moment, so that's why I can't join you. But I can see you all sort of in the distance there, which is really nice. Along with overseeing the programs at ILC, I lead on measuring and maximising our impact, which is, a very interesting challenge. But I think as a relatively new member, if I can still say that, of ILC, just over a year now, I've been hugely impressed with the impact that the team have had with the prevention programme over the last 2 years. It's really established itself at the forefront of the global prevention agenda. And I hope you'll see a lot of the evidence and the findings that we've come up with in the last 2 years and think the same. Just among a few things, really, we have influenced the UN's Joint Decade on Healthy Ageing, the WHO immunisation agenda, and we've been described as international leaders in the ageing agenda. So for me, in my role, part of the challenge has been, how on earth do you go about measuring and creating value from ideas? I looked up the word innovation, and it's commonly defined as turning an idea into something that is viable, desirable, and feasible. And I'm truly awed and excited by the potential of this room today to really ask the challenging questions and to turn those ideas into actions. So the next 3 days really are about asking those challenging questions, really discussing extremely important questions. And as such, we'd like to spend the time with you to explore the commitments that we can make personally in the work that we do. We'd also like to share with you what we're calling our Anisee Declaration. So that will be available at the back of the room. Lindsay, would you be able to gesture in the direction? Great, thank you very much. So this is a statement of our intentions, our aims for the future around the prevention debate. And what we're looking for in the next few days is your input, but also ultimately your support of this statement. We've kept it very simple, but that is available throughout the next few days. So please do take a look at it, and we very much welcome your thoughts and your support if you would like to sign up to it. So I didn't want to take up any more of your time, but very, very excited to take part in the conversations and look forward to taking part in the rest. Thank you very much, and I hope you enjoy the next few days.
Great. Thanks, Kate. I'm going to pass over immediately to my colleague Sophia, who's led some work we've been doing, firstly in the UK, then globally, and then most recently looking at different G20 countries in terms of the sort of the economic contribution of ageing. As I say, we really wanted to frame the debate around actually there is this economic contribution to be made. I think one thing argument to be made. One thing that I just want to perhaps announce at this stage is we're planning an event in Washington in June with AARP, and then in Japan at the British Embassy, both to push this agenda, and I hope that you or some of your colleagues may be able to join. We're also, as the first event of the next stage of our prevention programme, planning to have a dinner with the ambassador in a dinner event with the ambassador in Japan. So I hope as many of you we can squeeze in the room will join us for that. Sophia, can I pass over to you to kick us off?
Thank you, and it's really great to be here, and it's lovely that we're all here together to discuss these really important issues. So I'm just going to discuss some reports that consider the link between health and wealth. We've done a number of reports, mainly our Healthy Wealth Global Longevity Dividend Report. We've done some kind of more recent work over the last year as well. So kind of framing the debate, as David mentioned, we often fixate on the economic costs of an ageing population and actually forget that older adults are making significant social and economic contributions, and they're growing as our populations age. So that would be through working, earning, consuming, but also volunteering, caring, looking after grandchildren. These are often ignored. And what we do find in our research is that again and again across countries and within countries, health underpins these contributions, it underpins the longevity dividend, and that we need to invest in prevention in particular to kind of realise this opportunity rather than fixate on the costs, focus on this opportunity, and that will help pay for these costs and address these challenges. And as we'll talk at the end, we're calling for countries to invest at least 6% in preventative health, as Canada is doing, but then to build upon that going forward. So if I just start with kind of different aspects of the economy, so if we start with the workforce, what we see is that across G20 economies, generally speaking, employment rates at older ages are catching up with younger age groups. And, we see that there's increasing financial necessity to do so as changes in public pensions policy become less generous as population ages. But also many people are choosing to work for longer, using those extra years, and often in good health, to remain stimulated and remain in the labour market. And that, combined with the fact that there's more older people as our population ages means that the workforce is ageing. It's ageing quite fast. So we estimate that by 2035, 40% of the workforce could be age 50 and over. So if we're thinking about a productive labour market going forward, we will need to focus on older adults increasingly. But these were kind of pre-COVID trends, and I'll mention that later. We did some scenarios that still expected to increase, based on COVID, but yes, that's obviously these trends were largely affected by COVID and health. And a final point to note is there is significant variation across countries in these trends. We're generally seeing this increase in employment rates at older ages, but that's not the case everywhere. So to give an example, we're seeing falling rates, for instance, in Romania at older ages, and Turkey and Brazil in certain age groups. So, that's not happening everywhere. There's a key point to note. And what we're seeing is we're seeing this ageing workforce, older workers' earnings are growing in importance to the economy in nearly all EU countries and the G20 as a whole, generally speaking. But again, there is variation across countries. And kind of generally speaking, every third dollar is earned by someone aged 50 and over across the G20. By 2035, older people could generate about 40% of all earnings. So really significant contributions. But again, I was talking about that difference across countries. So for instance, we're seeing actually a fall in older adults' share of total earnings and GDP in Romania in recent years. And again, that's linked to employment trends. So really highlighting that not everybody is kind of maximising that. Those countries. I'm not trying to single a country out, but just, this is not set in stone. We have to kind of act to ensure that older adults are able to realise their full economic potential. And we just did some scenarios, and it was quite interesting looking at beyond the G20. There's really high employment rates at older ages in Iceland, so exceptionally high. We kind of did some scenarios and found that there's a huge economic prize from reducing barriers to employment in later life. So if we enabled older adults to work at the same rate in G20 economies as we see in Iceland, that could add about $3.7 trillion US to GDP across G20 economies. So that's about a 7% GDP gain. So in these cash-strapped times, it's quite interesting to think about, these kind of the potential of doing what is already happening in other countries. If we turn to the consumer market, again, we're seeing a similar pattern. Older people's consumer market share is growing, generally speaking, across the G20. Again, there's not happening every single country. And again, there's two key trends, obviously more older people as our population ages, but also the average older adult is spending more over time. They're working for longer, also changes in pensions policy, etc. So we're seeing those trends happening alongside each other. So the combination of that means that, on average, older household spending amounts to over 50% of total spending, and that is on the rise. And across the G20, this spending actually exceeds the GDP of Japan, Australia, Canada, and Brazil. So there's a significant export market that's growing. We really need to kind of focus our attention if we're thinking about consumption, boosting consumption going forward. And again, as I mentioned, some key kind of sectors that are growing, recreation and culture, in particular transport, is growing really fast across many economies. But again, it's not happening everywhere. And we see in some countries where there's really a faster growth in employment rates, we're seeing faster growth in consumer rates among older adults. So that link between employment, income and consumption, obviously many other policies. So there's variation across countries. And finally, turning to unpaid contributions, we know that market contributions do decrease quite significantly after the age of 65, but we often forget that unpaid contributions rise significantly at these ages, and we find that across the G20 and EU countries, adults aged 65 and over spend more time volunteering or caring than other age groups. And if these were remunerated, we calculated that unpaid contributions by people aged 50 and over in the EU and Turkey would average about 1.4% of GDP. So that's more than what the EU, at least previously, was spending on defence. So really significant, often forgotten. And again, these unpaid contributions often exceed the market contributions. So if we forget about these, we're basically neglecting a really significant part of the contributions old adults make. So as mentioned, we've talked about that variation across countries and trends and levels. I've had to go through this quite quickly, but there is significant variation. And obviously the many factors that are driving this. But a key one, of course, is health. And we do see quite conclusively in the evidence that good health enables both market and non-market contributions. And firstly, we looked at individual level data across European countries. And we saw that older people in better health who have good cognition, so looking at kind of good cognition, but also physical health outcomes like not limited in daily activities or report being in good health, are more likely to be in work, volunteer often, and spend more. And this is found across countries, and including when we control for key factors like income and GDP. So health is really key for a longevity dividend. And similarly, when we look across countries, this is not done as so often, and considering how that variation contributions, what we see is that employment and spending rates of older ages across OECD countries are higher in countries that spend more on health as a share of GDP, spend more on prevention. An example of that is have higher flu vaccination rates, so we do see an association there, and have healthier older populations. Similarly, older people spend more time volunteering and looking after grandchildren, so doing those unpaid, really vital contributions in countries that spend more on health as a share of GDP and where older people are healthier. So again, across countries, we're seeing that, and again, controlling for factors like income and GDP that could deal with that variation, as you see with that graph on the right. And I think there's two key opportunities in terms of investing in health to boost these contributions. Firstly, it's kind of realising the trends that we're already seeing going forward. They're not set in stone, they're not inevitable. We've seen since COVID, there was a completely backwards a kind of drop in consumption by older adults, and we've seen a significant decrease in labour participation rates across older adults across many economies, and that's helping to cause labour shortages at the moment. So, really, they're not set in stone. We do need to act and invest in health to ensure that happens going forward. But there's also, we can go over and beyond that. So I talked about the Iceland scenario. That's definitely going over and beyond kind of trends in most countries. Also, in terms of spending, we do know that consumption actually falls among the oldest adults, so 70, 75 and over. But this is not explained fully by a drop in income. So people have their income to spend, they're actually saving more. And we think that the evidence suggests that health is a key barrier to spending at those ages. So there's a key kind of unmet market opportunity to boost spending at those ages, because if we look at trends, that's still that kind of drop at older ages is still set to kind of last going forward, 2040 and beyond. So there's still a lot more we can do. And it's also important to note that there's a cycle. If we invest in health, there is evidence that older adults spending on leisure and different activities, leisure and tourism, for example, is really important to support good health, physical and mental health outcomes. And so that's a kind of reinforcing cycle, and we saw that broken in COVID. And kind of specifically on prevention, we know that I think it's really important to focus on this. McKinsey have estimated about 40% of kind of key health problems are preventable, so it's largely preventable diseases going forward that we can act, and we know that's far cheaper than kind of treating these diseases. And our research finds that investing in prevention across countries by simply 0.1 percentage points could unlock a 9% increase in spending by older people. And to put this in perspective, that would be about $180 billion to the US economy in 2015, or about 1% to GDP. Similarly, that could add about 10 more volunteer hours per older person each year. That would increase volunteering by about 50% across the EU. So really key changes are associated with increased preventative spending across countries when controlling for factors. And it's important to note that investing in prevention is indeed an investment. It's likely to pay for itself because of that link between health equals wealth. And McKinsey have estimated an economic return of about $2 to $4 for every dollar invested in improving global health. And I'll turn really quickly to some specific examples of prevention and that link between health that we've kind of looked at subsequently. So our kind of 2021 Up in Smoke report looked to really focus on that link between smoking and healthy life expectancy and years lived in good health, and kind of noted and is backed up by the research that smoking has an impact not just on life expectancy, but the impact on healthy life expectancy and people's ability to work. And we found that if current or ex-smokers had never smoked in the UK, overall earnings could be about 1.9% higher and would boost the UK economy by £91 billion every year. Similarly, if we turn to the flu, that has a significant impact on people in better off countries. Our research showed in 2019, it's about 19 million people are affected generally each year. and that costs around 159 million in working days each year, so equivalent to $39 billion in lost productivity. So again, in these cash-strapped times, really important figures. And finally, we've got a kind of recent report looking at the cost of inequality, looked at differences in health outcomes across areas in the UK. We know that health inequalities are very high and growing in the UK at the moment. That's the case in many other countries. And we're kind of seeing how that relates to economic outcomes. And we saw that areas where people are living in fewer years in good health actually are working for fewer years on average. So it means poor health is likely the biggest barrier to working longer. That was a key conclusion of the research. And we saw in those areas people are spending less time in healthy retirement, but also on unpaid contributions like volunteering and caring. And of course, we're seeing high social care costs, healthcare costs and financial support. So we tried to kind of estimate that, what that impact in different scenarios. One example is a 1-year extension in healthy life expectancy based on this variation would add about 3.4 months to working lives, and this could reduce income taxes required to pay for kind of public services by 0.6 percentage points. But this could be far higher if you increase the state pension age in line with this kind of health gain. So there's so much potential to link health equals wealth, not just across countries, but within countries because of the high inequalities that exist. And a final point just to mention is, we keep hearing all the news about labour shortages, current and future labour shortages, and I think investing in prevention is also really important, might play a key role in tackling these issues. And just to give some context, our kind of Missing Millions report found that 26% of people aged 50 to 64 who are jobless would actually like to work, so they're involuntary unemployed. That's over 1 million people below the state pension age. And poor health is the main barrier to this, as you can see in the graph on the right. And our recent research also projected a shortfall of 2.6 million workers by 2030. That's about twice the size of the NHS workforce, a really significant shortage, largely due to an ageing population, but also because of the impact of COVID and Brexit. And going back to that former point, because of that impact of poor health on involuntary unemployment, it's absolutely vital we start tackling that to deal with that. But of course, there's also, to make things more fun, the current labour shortage in the UK, and it's also seeing that in other countries. Obviously, that's complex and lots of factors affecting this, but there is a lot of evidence that health is playing a key role. We know that actually a decrease in kind of inactivity among older adults is really key to driving that labour shortage in the UK, and there's a lot of evidence by the ONS, the Trade Union Congress and other reports that poor health is having a key factor to play in this, and actually long COVID might be having a key role in long-term sickness. So really need to be thinking about these current challenges as well. And finally, we've kind of made this case that investing in prevention supports wealth, but we're really not doing enough. That's why we're all here. As we'll mention later, we really need to invest at least 6% of our budgets on prevention. But in most G20 economies, are spending less than 2.5%, and some economies have gone, some kind of spending has gone backwards since COVID. So outside of COVID budgets, we're seeing actually falling spending on prevention. And again, health inequalities were wide and growing pre-COVID in many countries, but that has been exacerbated. And a final point to note is in kind of ageing commitments in the whole across the G20, only 0.35% of all G20 commitments are focused on ageing. And given the significant issues and that kind of issues in terms of prevention spending, we really need to do more. So we're arguing we need to have a more structured and coherent approach. So we have been calling for an ageing society New Deal, and obviously the key kind of recommendation is to increase our spending on prevention, tackle health inequalities, and really recognise the value of health, economic value, and we think complementing GDP with a measure which factors in health and inclusion can really help to do that. Kind of beyond this, we think there's other important factors beyond investing in health. So, for instance, supporting work in an ageing, changing world, thinking about those labour market shortages, really need to reduce the barriers to employment in later life, invest in lifelong learning, thinking about consumption as well. There's so many exciting opportunities for businesses to tap into that policymakers can support with different strategies. And we also need to reduce barriers to spending in local communities and ensure that they're inclusive to people in poor health, so to prevent poor health, but ensure that people are able to participate and spend in the local communities, even if they have poor health. And finally, recognising and supporting unpaid contributions are often neglected, and that's, I think, leads to inefficient policy decisions. We're often not thinking about the impact on these unpaid contributions, give more support to informal carers, and enable and incentivise volunteering at all ages. And finally, just to conclude, kind of key messages here, we've often fixate on these costs of ageing, but actually older people's economic contributions are significant and growing, but also not inevitable. We do need to support these contributions going forward. We've seen that good health underpins longevity dividend, both across and within countries. Health equals wealth. We talked about those different mechanisms for this. And investing in prevention is particularly key. It's much cheaper than waiting for treatment costs down the line. And we've talked about the impact on working lives, tax uptake, but also social capital and labour market shortages. And finally, as mentioned, ageing policy is fragmented, and that's why we're calling for an ageing society New Deal. So thank you.
Great, thanks, Sophia. And I think one thing that's worth reflecting is I think we think that our ageing society New Deal isn't that different from a Green New Deal. Actually, good jobs, nice environment, creating the right sort of work, the right sort of consumption is absolutely consistent with the sort of environmental movement, which is really important. And I think whilst Sophia's highlighted the economic opportunities, I think one of the challenges that clearly comes, it actually highlighted at the moment from the UK is, there are clearly opportunities for us to get to policymakers and say, look, there is a case for your investment here. But on the other hand, governments are under increasing pressure as a result of cost of living crisis and ageing, frankly. There is a risk we move more towards acute as opposed to preventative care in the context of ageing. And in the UK alone, for example, last month the government announced that they were planning not to continue to provide the flu vaccine as part of the schedule for people aged 50 plus. It's going up to 65. Actually it strikes me that in a year we need to focus on tackling respiratory diseases that sort of potentially retrograde, but equally actually going against the JCVI recommendation around teenagers, and whilst they had access last year, they're not going to have access this year. And it strikes me that on the one hand, whilst we have this evidence, actually that governments are under fiscal pressures. Questions for Sophia? Comments from the audience here? Go on, someone's got to be first.
I've scared you.
Go on. Speak into the mic. Yeah. I don't think it's got. Has it gone up? There you are.
Okay. I come from France. I more than agree with all you say. My concern is how to make all this understood by younger people, because we are living in societies thinking mostly of young people. And I heard several times my government saying we have to get an impact on youth and jobs in youth, and they are totally forgetting elderly. So it's my real concern is how we can join the two and try to have a continuous perspective. Thank you.
Absolutely, and I think I'd say that ILC, certainly in the UK, would very much see ourselves as a life course organisation, and with this programme we wanted to focus on prevention across the life course. Sophia, have you got anything? I might pick on Tilly to say something. Sophia, do you want to respond on that first?
I don't know necessarily the solution, but just highlighting, it's very important, and it was quite disturbing to see some of the rhetoric, during the pandemic really kind of, some really negative rhetoric about older adults and really negating their significant contributions. And so I think it's just absolutely vital that we really pick up this debate and, really keep highlighting this issue. But in terms of actually solving it, I think it's just keep kind of highlighting. And again, those unpaid contributions often really neglected. If we're only focusing on market contributions, we're ignoring such a significant portion that we just don't often talk about.
No, absolutely. Do you want to say anything, Tilly or Mike? Sorry, and I don't mean you to be our token younger person. Sorry.
I think that's interesting. I think so I work in the field of food, and I see food as a really powerful tool in bringing generations together. And I think seeing that intergenerational aspect of this conversation is really important. How can we bring these for instance, social isolation and loneliness is obviously in Scotland at least, a an issue, but lots of younger people are having those same challenges. So how can we take that approach? And food is a really powerful tool of doing that, whether that's like shared meals or maybe an older person's teaching them how to cook. You know, that sharing of skills, you talk about that wider social impact, I think is really important, rather than necessarily, oh, you need to vaccinate them 10 years earlier. What else can be done in that wider part of life and society?
Great, thanks. John, did you want to, and then Paul?
This one, okay. Yes, Sophia, I totally agree with everything you've said. My only qualm is I don't think the evidence is as strong as you suggest. And I recently had to do a report for WHO looking at the economic case for healthy aging, and that even a valid summary of the contributions of older people in the different forms you're talking about. And by the way, I think you need to emphasize tax. The tax older people pay more. Older people pay a very significant proportion of tax. That it's very hard to actually get all that in one place. And I think this is a job that the ILC could look at. And in fact, I've often had to fall back on a report I think came from the ILC and maybe Age UK about 10 years ago, which looked at the balance between the costs and the contributions. So, and also I think the evidence that health actually, I mean, I totally agree with what you're saying. Health clearly is a determinant on what you can and can't do, but the evidence is not as strong as it should be. And I think trying to encourage researchers to fill those gaps would be really important as well.
Yeah, thank you. Paul from GSK, by the way. A question, you said from McKinsey figures is a return on investment of investing 1, 2 to 4, getting out of that. Yeah. What is the time frame also to when would younger people benefit from the fact that I got better prevention now? Because that can also make the case in terms of when really to start and why we should start now.
Yeah, no, I think that's a really good point about the time frame that might deter policymakers from investing. I'd need to check, I could get back on that report, but that's known preventative health interventions across the world. I'd have to see about the time frame, but that's, you know, they know that these exist, that this could, you know, make that kind of impact based on what's already been developed.
Because it's sort of, if you got your political mandate of 4 or 5 years, we'd say, you know what, my problem is now, I'm going to solve that one, and we'll see after that. And I think somewhere you need to make the case, like what it means over time and who will benefit, not only the people, older people, but also people, younger people.
I would say just on that point, maybe, I think something in terms of the point about older adults working for longer, there is often this idea and narrative that actually steals the jobs of younger adults, but a lot of the evidence actually shows that if older adults are working for longer, they're spending more, and actually supports the job opportunities and incomes of people of all generations. So I guess investing in prevention could have that benefit that way. But no, it's a really interesting point, making those kind of indirect links.
Mark and Lois, do you want to go towards a mic, or get Lindsay can give you a mic? Mark, do you want to go first?
So to follow up on Professor Val-Olivier's point, I think there's a failure of advocacy here. We know that across at least the post-demographic transition countries of the G20, older people are much more likely to vote than younger people. We know from your data there are lots of older people who would like to work but can't because there's been an insufficient investment in prevention. So it ought not to be genius, right? It shouldn't take a genius to convert that dissatisfaction, that current shortfall into political pressure. The UK, for example, I think the figures are that an 80-year-old is 4 times as likely to vote as a 20-year-old. I think that's right. So mobilizing political pressure in that context really suggests that somewhere there's been a failure to explain and to mobilize.
Yeah, absolutely. Lois and then Catherine there. I think we'll move on to the next panel where plenty of opportunities to add.
Yeah, thank you. There's a lot of good data here. The one concern I have is about aggregating it all together as G20. You have a lot of variability between the countries, and I think the issues are going to be different from country to country. So you may want to really consider digging deep into those countries rather than, with a blanket statement. the 6% seemed very high to me. So, when I saw that, I immediately, I just wondered whether that was going to work in most of those countries, because that is a long leap. So thinking about, the stages that you might take to get there and what's reasonable. The other thing that I would also consider looking at is the impact on productivity of the younger generations, because many of them are caregivers, have to take time off of work. So it's not just the costs associated or the lost costs associated with the older adult. I think we need to take a more holistic view and look at the impact on all generations, not just older adults.
Great. Catherine?
If you allow me, on the same line as the previous speaker, I would like to focus on the disequilibrium between the workforce of the young people and aging people. And the young people say, we don't want to pay anymore for the retirement of the older people. And so it's a political issue, at least it is in my country. And when you see people in their 20s or 30s, unless they are parents with young children, I'm very happy that grandparents take care of their kids. Otherwise, we won't pay for you anymore. And so it's I do agree with the fact that you need really a holistic approach and really try to understand where are the benefits, where are the caveats, and what is the good way.
It's really interesting to speak to your point earlier about, encouraging both generations to feel, to understand, the benefits of this kind of approach.
Great, thanks, Sophia. Sophia's coming back tomorrow to talk about the piece of work we've done around social media and vaccine uptake. So we will add a bit more then. Lindsay's going to sort some chairs out, and while she's doing that, a few sort of final thoughts from me, and I'm going to pass over to Aaron. I think one of the really interesting questions remains the impact of ageism in this space, and a sort of interesting thought exercise around had COVID impacted younger people in the way the Spanish flu did? Would we have been saying to younger people, you need to stay in your home, you can't leave? Whereas, of course, we said to older people, you can't have any visitors in your care home. We had, there was real ageism in the way that we dealt with and supported older people, which I suspect wouldn't have happened. So I think ageism remains a big challenge in this space. I think equally, if you look at Google word searches for April 2020, there's this massive upshoot in the word vulnerability. And, actually vulnerability itself is a really difficult term, and I think increasingly being challenged in this space, because vulnerable to what? But one of the things that's really striking is all of a sudden people realised there were people who were more likely to find themselves, in a place where vaccine preventable diseases, or where diseases were likely to impact on them hard. And then the final point, before I pass over to Aaron, is with the support of Sanofi, we are producing country reports, a country report for every G20 country. So absolutely want to be getting out to individual countries. And then the cynical position about the sort of the investment in prevention and the engagement of Treasury ministers is that actually there is, when we did the first SARTI report, which some of you were involved in, there was a real sense then that Treasury ministers tended to feel that if people lived a bit longer, we had to pay their pension a bit more, and that actually this really screwed the cost benefit in terms of lots of health interventions. And I think something we do have to take account of. At which point I'm going to pass to Aaron and our next panel to come and join us. So Aaron, we have who do we have? John Beard, Julia, Biella, and Nicola. One thing to say, so we're going to talk a bit about sort of for the next sort of 45 minutes or so about lessons from COVID. We did a piece of work. Do come to the front. Did a piece of work looking at all the really interesting and innovative things that different countries have done as a result of COVID. And one of the things that really stopped us, and John just made this point, is that actually there were loads of innovations, but there wasn't really very much by the way of assessing whether any of them actually worked. So we had this report that was, I think in the end, sort of huge numbers of case studies across the world, and it's like, we look at them and think, well, actually, did that mean France was better than England, or England was better than Spain, or was the app worth it? Was there? And actually, I think one of the real failings we've had with COVID is, frankly, we just didn't make the most of the opportunity to learn what really worked. So this is an opportunity for us to correct that, and I'm going to pass to Aaron and shut up. But thank you.
Thank you. Really delighted to be here with you all today, and to be chairing today's session on learnings from COVID. I'm Erin Himawan. I'm a research fellow at ILC, and I lead on our global health program of work. I think, in many ways, COVID has served as a global health, preventative health case study. And in today's session, I think it will be really great to kind of think about, take stock and reflect on what we've learned from the pandemic. What have we done well, and how can we potentially use that as we move forward to address and tackle, global burden of health? But also, what have we not done so well, and what can we learn? What is the room for improvement as we move out of the pandemic? So in this session, we'll think about sort of the good and the bad. We'll also be thinking about the long term. Has the pandemic created a renewed focus on health promotion and prevention of disease? Or do we actually have more of a backlog and tighter spending than ever before? And we will also be looking into the horizon to get a sense of what needs to happen for us to see a fundamental change in global health, the way we tackle that burden. What is the key thing that we need to see happen for us to actually see improvements and drive improvements in health? So to think about these questions, to discuss these questions, and they're not easy really to answer. We are, however, joined today by a really excellent panel of speakers. So they will be briefly speaking, giving their opening thoughts, and then we will have a little bit of a discussion. So I encourage everyone to contribute. And those of you joining virtually, obviously, please do use Slido. So without further ado, I'd like to first introduce Professor John Beard from the ARC Centre of Excellence in Population Aging Research at the University of New South Wales. I'm happy for you to present there, if that's easy for you.
Great, thanks. And I think the first thing we have to remember is it's not over yet. It's one thing to take stock, but to think it's all over and now we move on to the next thing, we can't be thinking like that. But as we look back, it's not working. Okay, I just have to put it closer to my mouth. I guess as we take stock, though, and we look back, we have to say that the experience has been mixed. Really, there's been heroic efforts by underfunded health services to deliver services, which we have to acknowledge how, the stress that people who are delivering that have been under, and been able to do continue to perform under those sorts of conditions is amazing. But on the other hand, there's really clear information that we have systematically let older people in institutions in particular down, and older people who require home care down. And why would we be surprised? In places like the UK for 10 years, we've seen systematic disinvestment in these areas. And in other places in Europe, older people who were presenting to hospitals were sent home because they didn't want to, from institutions, were sent back to the institution because they didn't want to stress the health system further. And this reflects what I think David was talking about before, some of the outdated stereotypes and attitudes and the pervasive ageism, which really drives a lot of government thinking. On the other hand, if we look at the private sector, it's been incredibly nimble. Really, to think that we could have such effective vaccines developed within 1 year and available to the public is just, we would never have imagined that could have taken place. And I think in doing that, there's another thing which we often overlook, which is just as important. The testing, the clinical trials which was undertaken to develop those vaccines was done on older people. It included older people in clinical trials. And those of you who have seen clinical trials in many of the other drugs which older people use will know it's actually tested on
people who have no sort of physiological similarity to the person who's actually going to be taking the drug. So I think that is to see that we can do that at such a large scale, and to see that we can move forward in that very different way is really crucial. But on the other hand, I think, so Big Pharma, I think it's a big tick, but I think we also have to look at international inequities in terms of access to the products that have been produced, and we need to think about how can we have much fairer ways of ensuring that people all around the globe who need these vaccines and other products can get access to them. The other private sector group, which I think has been really nimble, is the home care industry. I think there's all sorts of innovative home care which is being developed, and I think that's really critical as we look forward from this point in time. I'd like to come back to David's comment on vulnerability, because most of you who will have been following the pandemic will know that people were identified at greatest risk by chronological age. And if you were over 65, there's some sort of magic line in the sand where suddenly you became you had access to a vaccine before somebody who was under 65. Yet we know that chronological age is a really poor marker for vulnerability. And I think the lesson we need to take is how can we better understand what really makes a person vulnerable to these sorts of conditions. You know, there's a lot of good work happening in that space in the field of geroscience. I think we really need to push forward with that very quickly. And then finally, I think we are at a point where governments are really open to thinking about how can they do things better. I don't think it's going to last for a long time, and I think they don't have much money. So the time to sort of impact, the time to convince them to spend, to do some innovative work is now. It's not in a year's time or 2 years' time. And then, sorry, the other point I wanted to make when we talk about vulnerability is equity. If you look at a distribution of vulnerability at any age group, the people at the bottom, the most vulnerable, are also those who've had the least advantage across their lives. And so we have these self-reinforcing cycles where people become vulnerable earlier, but they may be denied because of chronological age, whereas people who actually don't need whatever's on offer as urgently have access to it. And so we have these self-reinforcing cycles of inequity, and I think we need to think about how we can do that better in the future.
Right. Thank you so much for that. I think you're, highlighting the point around inequity is clearly something that I think is for anyone who works in global health is clearly kind of the priority. But understanding how we actually address it is much more difficult. And like you said, we can't just look at things like age as an indicator of inequity. Actually, it goes much deeper than that. There are lots of system barriers that contribute to that. So really interesting to maybe pick up during the Q&A discussion. I would now like to introduce Julia Farah from the United Nations to give her brief thoughts on this topic as well.
Thank you so much. And before I begin, I want to thank the organizers for inviting the UN program on aging, and also just, for your sake, I have a really bad case of seasonal allergy. It's not COVID. I've been tested, but sometimes it looks like COVID, but it's not. So don't worry. Okay, so my team has spent already a bit of time trying to understand how COVID pandemic has impacted older persons, and we have looked at social protection, economic issues, access to healthcare, social isolation, etc. But what I want to talk to you about today very briefly is 3 cross-cutting issues that we've seen in all these dimensions. The first one you have already raised, Catherine raised it, and John and David has also talked about this, and is that the pandemic has shown how widespread and pervasive ageism and age discrimination against older person is, and how negative its impact is on older persons. And we have seen this in many examples. I think someone mentioned the rhetoric in public spaces. We even saw politicians showing a lot of stigmatization in their discourse. We saw it, for instance, in my country, my original country, Spain, where there were cases and reports of people who were abandoned in care homes to their death by their caregivers. We also saw it, as John was mentioning, in the access to healthcare. So this is something very important that whatever we do and we talk about in the next 3 days, we need to keep in mind and apply an ageism lens to all our discussions. The second point that I wanted to raise is that the pandemic has amplified existing inequalities, both between older persons and other generations, but also among older persons. And this talks about the great diversity that characterizes old age and is very often lost in public discourse. And so you can see this, for instance, between older men and older women. We know that older women live longer, but they also have they are more likely to suffer from a disability or to receive long-term care. And because of inequalities experienced throughout their lifetime, they're also more likely to be economic insecure. So of course, the consequences and the impact of the pandemic are going to be very different. Where I reside in the US, not the UK, there's so many British people. In the US, data show that people from ethnic minorities had a higher mortality rate than white people. Between generations, we saw it in their response, and I think it was David who mentioned the lockdowns. I think at the time it felt very natural that we migrated to the social sphere, but this was done very often without awareness of the digital divide that a lot of our older persons experience, and so it was not done in an inclusive and mindful way that would ensure that they're included. And of course, I want to talk about the great differences experienced by older persons in developing countries, where they faced a lot of people, but of course they had access to better protection in terms of social protection, adequate healthcare, etc., than those in developing countries. And this brings me to my third point, which is that the pandemic has made clear that we really need to emphasize the need for more data and more research. Data that is disaggregated by age, by gender, by disability, location, and any other characteristic that we deem important. This is, of course, as the other two issues, this is nothing new. We've always known that we need more disaggregated data and more research. And without it, we can really not make policy recommendations that are effective. So it is really a precondition as we think on how we can move the agenda of older persons forward. And so in that sense, I hope we're able to integrate in our discussion and also to support initiatives like that of the Titchfield City Group on Aging and Age Disaggregated Data, which my team supports, and that has been working for the last 3 or 4 years in trying to improve the capacity of National Statistical Office and develop standards on aging data on older persons. So, I mean, in a way, I think the pandemic has been a stress test on the capacity of our world to adapt to population aging, and what we have found has not always been very positive. But as David has mentioned, it also gives us an opportunity. I joined my team in 2019, and it was a shock to me to realize how little I knew, but also how little the world knew about older persons as a group. And then a year later with the pandemic, I really saw the world go through the same transition of suddenly realizing how much we need to do for older persons. So I hope we take this as an opportunity, and I hope we keep these ideas in mind in the next 3 days. Thank you.
Thank you so much for your comments. And I think, very key point here is that we can no longer look at older adults as just a homogenous group. We really need to disaggregate. And when we do, as long as we don't have data on this, we should not be surprised when we see inequalities in health. Because like you said, we are flying blind without that. And without the data, we can actually drive those solutions and implement the correct solutions to tackle these big issues. So really, really interesting points there. I'd also now like to invite Biela Roberts from MSD to give her thoughts.
Yeah, sure. Thank you. And thank you all for inviting me and being here. So I wanted to talk a little bit more about life course immunization and how COVID-19 has really been a very stark reminder of the role that vaccines play when it comes to protecting our societies, but also, for example, our economies. Now it really plays a huge role when it comes to global health. We really see with life course immunization the protection indeed from infancy to older adulthood. And it really, what we saw during the pandemic was that need for a paradigm shift, right? Because a lot of the times when we talk about vaccination, it's about pediatric vaccination, unfortunately. While we saw right now there is a big need to take life course immunization and also adult immunization very, very seriously. because life course immunization, for example, also enables healthcare systems to be, better responsive when we have a new threat, when potentially, and hopefully not, but a new pandemic comes up, other vaccine preventable emergencies. Having that infrastructure and health system ready for that is very important, because right now we're a little bit behind the facts, and we're trying to play catch up as such. And it's also really important, right, to see how life course immunization can relieve those health systems, decreasing the burden of diseases, but also, for example, hospitalization costs, etc. But it does require a timely investment from governments. And we do see a great return on investment, for example, if we look in immunization, but often implementation is lacking behind. If we look, for example, at Immunization Agenda 2030, which I think is a great initiative and very ambitious goals, but often the implementation on the ground at country level, we see a lot of operational barriers that need to be addressed. And what we see right now in certain regions like Europe, North America, but also Asia, for example, is that aging population indeed. And that importance to make sure we preserve older populations from falling ill, but also indeed, we cannot afford to lose any young healthy lives when it comes to an aging population. So indeed, taking into account that full spectrum is very, very essential. And indeed, with the Decade of Healthy Aging, great initiative as well, we really see, that aging, at least in my perspective, aging should be regarded as a continuing throughout your life. It's, your healthy age. I'm healthy aging right now. It's not something to think about once I'm older or just for older adults. And indeed, having that youth perspective perhaps in there, I think is very important to get that recognition that aging is something we can be working towards throughout our lives. And that includes indeed life course immunization as well. And that really can support helping reaching that healthy society as well as economy, as I mentioned. But indeed, at country level, right, we see a lot of differences when it comes to immunization financing, surveillance, delivery, etc. Also, when it comes to NIP inclusion, for example, some of them don't even have adult programs in place, right? And even the ones that do, unfortunately, vaccination coverage rates are in adolescents and adults, actually. See a cute dog. Has joined us. He's interested in life course immunization as well. But yeah, we see that that it has vaccination coverage rates, picking up where I left out. Even in those who have adult programs, for example, are unfortunately really lacking behind, especially in comparison to pediatric programs. And expanding vaccination coverage rates. So expanding vaccination coverage rates in adults, there needs to be a big shift when it comes to expanding those infrastructures, for example, as well. Really need shift in the programs, and also thinking about new approaches, how we can actually get those vaccines delivered, making sure it's very people-centered when it comes to our immunization programs, making sure we reach the people where they are. So I think to unlock the full value of life course immunization, there should be changes within policies, programs, payments, but also performance. So policy indeed meaning that we integrate, for example, life course immunization into healthy aging policies, and making sure national immunization programs take into account the full spectrum of protecting against vaccine preventable diseases, what they can do. Payment, of course, making sure there's sustainable financing and funding towards prevention. When it comes to performance, for example, also measuring performance, right? Surveillance, monitoring, but also that education on adult immunization and prevention, how important that is. And indeed, the study that we just saw, I think those type of messaging we need to get out there as well. And also when it comes to indeed those access pathways, when it comes to the program implementation, making sure those adequate infrastructures are there and that they are sustainable also for adults is of high value. So indeed, with the COVID-19 pandemic, I think we have a big window of opportunity right now. We have a lot of awareness, prioritization. I agree that it probably won't last too long. So we should definitely get to work and get to it. Thank you.
Great, thanks so much for that. And I think something that struck me that you said, we were talking about the structures in place that absolutely need to be there. And I think a lot of the time when we think about, addressing inequalities in health as well, we think a lot about these targeted interventions for certain groups. But I think especially with immunization, we find at the national level, even if we have these very basic structures in place, that can actually help to improve uptake across the board. And then we can start thinking about, or even indeed alongside, but some of these fundamental things still need to happen. And so we're still a long way from even having some basic access to vital preventative health care in many countries. That's still lacking. So clearly something that should not be overlooked. We often, or I guess the main point is that we need to think about even just going to the basics and thinking about how is this preventative intervention being delivered at a very basic level and addressing where that's not effective, where it's not effective. All right, great. Well, thank you so much for that. And I'd like to now pass over to Nicola Oliver from Medical Intelligence.
Thanks very much, Aaron. And again, I echo the rest of the panel in thanking you for inviting us here today. So I've approached really what I'm going to say from a public health and a healthcare resource perspective. And there were 2 or 3 things that really struck me when thinking about what went well. Well, we definitely saw some quite innovative healthcare practice. So the redeployment of healthcare teams in circumstances often that were very challenging to the teams, such as the redeployment of staff within intensive care. We know that an intensive care department will reflect very much what happens in terms of mortality from some of these infectious diseases. And also quite extraordinarily speed, which again John mentioned, in terms of how we managed to get a vaccine approved and out there in under a year. Now that of course caused some problems within itself because of the great skepticism that was faced by the vaccination programme. The general public didn't generally understand the way that a clinical trial was undertaken. So that was quite a remarkable route to seeing some great pluses. However, we didn't really have what I would consider, from my perspective, a public health readiness, a preparedness. And that really has been a major problem. We were firefighting the pandemic from the very, very beginning. And that really leads us to ask the question, why on earth were we not better prepared? Okay, so we were prepared for pandemics if they were going to be a flu pandemic. We knew what happened with an influenza virus. We knew exactly how to deal with that. We had vaccines. So in ways that things could have been done better, we should have learnt lessons from the past. Now, SARS was an extraordinarily fantastic blueprint of how we should deal with a coronavirus. Okay, so a coronavirus works in its own way. And we should have been prepared for the level of organ damage within individuals. And now what we're faced with is potential epidemic of what people are describing as long COVID. So there's a whole issue around why wasn't public health better prepared. Well, this comes back down to funding, of course, but also what is the function of public health? And in many social models of medicine, it seems to still be a bit of a firefighting exercise. So let's go right back. Let's look at the social determinants of health. I mean, when I did public health, studied public health, that's what we were taught to understand. That was public health, social determinants of health, reducing inequalities. And that's something that we really need to work on. And then go back even further. Is this not something that should be part of a core curricula at school? It's not something that young people should understand going forward, that in fact, public health is something that is a global response. And we should be approaching public health. We should be approaching preparedness for the next pandemic, because there most certainly will be one, in the same way that we currently approach such things as the climate crisis. This is not individualism. This is not different populations doing their best. This has to be a huge global response. So what could be done better? Well, investment in communities. A wider understanding of the impact of social inequalities on health. And also one of the biggest problems, of course, several of my colleagues here have mentioned this today, is the outdated stereotypes around older people and illness and their propensity to get ill. And when you mentioned, David, about the word vulnerability that had been explored, one of the less pleasant debates that was raging at the time, particularly with which was being combated by my colleagues in the actuarial community, is that some people would have died anyway. And that was really quite an unpleasant rhetoric to have to deal with. Even in the most extreme scenario with some of our modelling, 60, 70-year-old individual with all of the comorbidities one could think of still would have had an extra 5 to 10 years of life, not the few months that seemed to prevail. And this was something that was picked up not just in the general community, but even by some senior politicians. So, and that brings me to my sort of final point, really. What didn't work well and what needs to really work well going forward is trust in the people giving us the messages about how a pandemic could be managed, and the people receiving that message. And in populations where there was great trust in those who were perceived to be leaders of a community, then we saw much more interest and understanding of how to deal with the pandemic from an individual and population-wide perspective. So I think we've got an awful lot to build on: investment in public health, investment in communities, and to look at why these social inequalities are widening. If we look at the perspective of the UK, for instance, one of the things that we've seen is that those who have fared worst in the pandemic generally are those from the more disadvantaged backgrounds, sadly. And it's in those areas of the UK where catch up with the NHS is much slower. And this is where we're going to see an ever greater widening. So from a public health perspective, there wasn't a public health response because there was nothing in place. We have readiness for such things as emergencies. We're looking at climate change, but we haven't looked at what's going to happen with the next pandemic. And unfortunately, there will be one. Sorry.
We're all thinking it. I think you just said it. It's fine. And I think you raised a really interesting points here, and clearly this point around trust is something that people have been talking about over and over again, and something that we really have to think about, particularly with how we engage with different communities, and recognizing that there's different causes for mistrust within communities, and actually understanding how we can unpack that, because it's not going to be just one message that is going to work for everybody. We really need to think about where does that mistrust come from and how do we actually tackle that. So something that I'm sure we'll have to also address, not just for future pandemics, but generally when it comes to health messaging. So I'm going to now open the floor up for Q&A. I think I might just stand here if that's okay, so I can see everybody. Yeah, if anyone had any questions, please do raise your hands. Yes, Lois. Oh.
Yeah, not so much a question, but a comment built on the last point, which I think is very relevant. I think one of the real challenges is that when you're starting to talk about social determinants of health, that gets to the core of trust issues. It gets to the core of many of the issues that we're talking about, but we also have public health systems that don't address those problems sufficiently. And where they have addressed those problems, I come from Baltimore, and they did take a very concerted effort to address the vulnerable communities, yet it's through a surge approach. So they took, everybody that's working on any issue in public health and just, put them over to COVID for a period of time, and then it goes away, and then it perpetuates that lack of trust further. So, I think what's probably at the core of all of this is public health funding and consistent public health funding. I don't know what the solution is, but this is really where we need to get to.
Great. I wonder if anybody, yes?
Yeah, can I say something about that? Because one of the fears I have, while I agree that we need to have far better pandemic preparedness, is that that's what our response is going to be. It's about the next pandemic, where in fact the fundamental issue here is lack of funding for public health and these ongoing inequalities and the fact that we're not addressing them. And so I think that, we, in the messaging we give out to people, we really need to emphasise that if the lessons from COVID are not just about pandemic preparedness.
Yeah, really, really important one. Would anybody else like to? Yes, please go ahead.
Hello, John. I would like to start by
If you
John.
could just move closer to the mic, so thank you.
I would like to start by John and to come back to Nicola, because I think that the two talks are linked. You say, John, that in fact the vaccine was prepared in 1 year. I think that is not good, because people don't trust in vaccine prepared in 1 year. We have to know that behind the 1 year preparation of the vaccine, there are 60 years of preparation and research. And I think that saying to the public that this new event allow us to develop a new vaccine, anti-infectious vaccine, would be very good, because we have a lot of background behind. This vaccine was already tested in cancer disease. It was already tested in a few infectious diseases without success. But I think that putting it in a perspective of research and achievement would be a way of being trusted.
Yeah, I mean, I completely agree. One of the things that didn't really, I guess, get communicated effectively enough was that the clinical trial process was followed absolutely as it is with every drug development, but it was just sped up. So rather than this gap between every piece of regulatory approval at each phase, whilst they had another backlog of other drugs that were being reviewed, it was, think of a sort of relay race. The baton was handed from one to the next extremely quickly without this sort of lengthy process. So that I didn't really feel a sense that was being communicated effectively enough. So communication, again, number one problem. Second to that, the moment that the concept of a drug introduced into the body, it's not really a drug, but think of the RNA vaccine. The concept that somehow tinkered with your DNA really upset a huge portion of the population. And again, there were no basics around the fact, well, actually, as you and I are all sitting here right now, we're producing RNA, it's giving a message to our proteins, and then it disappears. This is something that we all do. So that never really became key. So once again, it's trust, it's communication, and giving the correct messages that make the best sense.
I agree with what you're saying, but I'm not sure it really makes a difference. I mean, the vaccination rates which we're seeing around the world are pretty high compared, to historical vaccination rates. I think the difference was there was this disgusting political opportunism which tried to build a distrust as a way of self-benefit. I mean, who would ever have thought that it was every American's right to die from COVID? I mean, it really. I take on board what you're saying, but I don't think it made any difference.
I actually I was going to say the same, because I live in the U.S. and honestly, I don't think it was. I'm not a public health expert, but I have the impression it was not an issue of communication or of knowledge. It was just a political issue. No matter what you have said, part of the population was going to say no. And now we're seeing that there's this very disconcerting situation where you see people who are I don't even understand. It's like now they want to put the mask because they're not vaccinated. And so that's also a political statement. So it gets very confusing because now you don't know. But from my very uninformed point, it really was not an issue of communication. It was politicized. I don't think it was to that extent in Europe. And I mean, I'm not sure what you do with that.
Mm-hmm. Yeah, navigating that, the mistrust alongside with these messages that are being put out really does not make the solution easy.
I mean, because, like in the US, it was the government.
Yes. Yeah. Patrick, I believe you had your hand up.
Yeah, just kind of on that point. I was discussing this with someone the other day about, and it comes back to what you're saying, John, then about like personal rights, perhaps. And I think you've sort of answered it maybe, but if people had a choice of vaccination, so the different type of vaccines that were on offer, do you think that could have helped increase uptake? And if people were given more autonomy, because obviously different companies produce different vaccines, but some were, as you say, Nicola, like mRNA, which people, there's a new technology, obviously billions were poured into it, so that's why it was produced faster. But do you think if people could have had a different type of vaccination say like a classic, like not live attenuated, but a different type, maybe they might be more willing to get vaccinated.
Well, that also became a bit political, particularly with the AstraZeneca out of Oxford, because, I mean, let's just go back to the flu vaccine, right? People don't understand what efficacy rate means, and they definitely don't care about that when they get their flu vaccine. The efficacy of a flu vaccine is probably about 50 or 60% if you're lucky. And we're talking about efficacy rates of 80 to 90%, so that wasn't going to convince anyone either. AstraZeneca's vaccine also, rolled out at incredible speed. But because the efficacy rate was a bit lower, that became political. European leaders decided they were going to not authorise that for use in people of certain age groups. So that was hugely damaging. So I think if you give people more choice, it's probably not a very good thing, given that as a foundation for what we saw. So what is the answer? I don't know. I mean, people don't care who produces their flu vaccine. They don't care, particularly the technology behind it. They don't fully understand. So I think sometimes giving too much choice in that situation may not be the answer either.
Yeah, I mean, and for the first time, people knew who was making the vaccine. I don't think anyone goes into their GP and asks, "I want this specific flu vaccine." So yeah, really, really interesting. Mark, you had your hand raised.
Yeah, I'm odd. I do go in and ask that, but I was bringing that as it's bizarre. And given who's sitting in the room, I won't say what I asked for. But no, I think in Ireland, I live in Ireland, so we had 93% coverage. And it's quite interesting, actually. The way the Irish system worked was you got a text message saying, "Here's your appointment, and here's the vaccine you're going to get." People didn't turn up, to your point, if they thought they were going to get the Johnson & Johnson vaccine, and they did turn up if they thought they were going to get Moderna and Pfizer. So I think to John's point, it depends on the country, it depends on the prevailing myth, it depends on whatever. But to me, the really interesting example is China, where older people didn't get vaccinated, and apparently there must be people who know this much better than me, but older people didn't get vaccinated because apparently they didn't perceive themselves as being at risk. And so a colleague of mine's son is married to a Chinese woman, lives in China as a medical colleague, and says he's been desperately trying to persuade his parents-in-law to get vaccinated, and they say, "Why? We live in a zero-COVID society, it's fine, I'll get round to it one day."
Thank you.
I wonder if the fact for elderly not getting vaccinated is linked to the idea that they were born in the 40s and 50s, and at that time vaccination were not so given in the society, so they don't know about vaccine, they don't know the use of it. It could be a reason.
Interesting. Yes. Paul.
Yeah, building up on that, but I also think what COVID has taught us, and I see that with my parents and also for myself, because it was earlier than my partner, and in the row of being vaccinated, we're used to vaccinating children, and even grandparents, they are used that their grandchildren are being vaccinated. But what COVID has also shown is that if you get older, you got a waning immune system. It's just what it is. It comes with your knee hurts, well, your immune system also hurts, in a way. And I think nobody ever explained that. We've never ever talked about it. So back to also what Bjella was saying, it's like this sort of shift of vaccinating kids to vaccinating kids and elderly, that is a sort of a paradigm shift almost. And then to the point, if you want to do that, and if you want to create sort of that awareness, because it's going to happen. We've seen at the beginning, like we want people to contribute for longer. So this can contribute to people contributing for longer. It needs to have education, public health systems need to be geared towards that. And that for me is really a quite significant shift that we all need to work on. And then earlier to my question, like how much time do we really have to really get a return on investment of that? I think we should start now in education and seeing public health investment not as something only for the next pandemic, but just to help us all in terms of a well-aging society. I think that's a critical point to work on.
Yes, absolutely. Anybody on the panel like to respond to that? Or great. Any other questions? Yes, David.
I shouldn't know how to turn the mic on, shouldn't I? Just very quick. So there is, interestingly, Nicola will remember, she spoke at the launch of a piece of work we did, published in November 2019, on the 100th anniversary of the Spanish flu, where we talked about the inevitability of another pandemic just 2 months before before COVID started appearing. So, we have a bit of a, it was our fault. But actually on that, just to bring back to the sort of pandemic preparedness point, there is a plan for a WHO instrument around pandemic preparedness. I'd be really interested, because I think over the next year there's an opportunity for ILC as part of this program to be thinking about actually how can we influence this. So I suppose there's a question about how we make, let's not be cynical about the value of it, how do we make the most of this opportunity, and then what would you want it to say? So I'd be really interested from the panel about what, if we've got this opportunity, bearing in mind John's point, actually, how do you use that to make the most of the opportunity to raise the issues we've been wanting to raise through this programme?
I think I'll just actually slightly rejig what I said about there will be another pandemic. We will always have emerging infectious diseases that have sporadic epidemic outbreaks. But I think we could perhaps realistically say we could prevent that becoming a pandemic with a much greater effort on this whole global approach, looking at what we did well and producing blueprints around the world. For instance, we know that there are some very threatening avian influenza viruses circulating in parts of the world, specifically in China, but we managed to, the surveillance is key. So investment in incredibly effective surveillance. We can't stop infectious diseases popping up. And we can think even going further back, I'm probably slightly digressing here, but I'm thinking about the way that some of these diseases enter the human species to begin with. So that goes back to looking at how we're impacted, the ecosystem, the movement of diseases from animal species to human species, the destruction of biodiversity within ecosystems. So that's a global effort.
And I think if you were to try and influence that development, you need to get the decision makers to broaden their perspective and understand that if you're going to be properly prepared for the next pandemic, you need to have long-term care systems which are adequate. You need to have mechanisms for ensuring that personal protective equipment can get to care providers. You need to have education systems for care providers, etc., etc. It's not just about quarantine, masks and vaccines. It's actually the infrastructure which really will determine the impact that a pandemic has, and to try and emphasise that as well, I think.
Yeah, absolutely. And I think especially the point around inequalities, if you have that structure in place, then we won't see inequalities in access and take up of vaccine, to the extent at which we did during the pandemic. Lois.
So I think, one of the things that can't be lost is we've actually achieved in many places like over 90% coverage. So, I think we need to stop and reflect and know that we're making progress. That being said, I don't know that you can believe the data everywhere, but, I think it's clear that there's been some progress made and we can't lose it. Now's the time to look at the gaps. Now's the time to look at where do we put our resources? Where do we put our efforts? It's not about, the masses. I think, we're getting to the masses. We're making some progress. It's about, where are those vulnerable pockets, the homebound populations, the people that are living with disabilities that can't get out and around. There's some clear access gaps that I think we do need to address. And I think we also need to get better at, honing our communication messages so they're not just general messages going out to the entire population, but that they're more tailored towards particular communities.
Sorry, I just quickly make the point what you said about the 90% coverage. That's completely a moot point if you've got populations around the world with, only 15% coverage, and we're just waiting for another dangerous variant to emerge, and that's what's happening. So we can't be isolated in our response. We say, oh, that's great, we've got 93%, when parts of Africa, South Africa, and other populations around the world have horrendously low offerings, not so much uptake, but the ability to get those vaccines to the people. And we just wait for another variant. You know, this isn't finished, as John said, this is not finished. And maybe Omicron is not a dangerous variant in terms of its risk to mortality, but that won't stop another one coming that will have a greater propensity to kill people. So we should have started thinking about vaccine equity from the very beginning, and not playing any kind of catch up.
Yeah, no, it is a very dangerous situation, and one of the things that I'm very concerned right now is the countries where you have uptake of, like DRC with less than 15%, that they can't seem to get it out. It's no longer an issue of vaccine supply, it's an issue of vaccine demand. But I think we also need to be thinking about systems and where we can start to make strides with systems and build on some of the wins that we have had, because there are some around the world. Now I think there's other bigger issues that need to be addressed, and it's clearly in the low middle income countries that's where a lot of our risk will persist. I think those are systemic issues.
Mm-hmm. Absolutely. Tilly, stand up.
It was going back to an earlier point. Yeah, you mentioned about education. So I did geography at university, and to me, a geographer has all those skills around seeing a social model of health. You learn about disaster risk management and preparedness, and I think maybe that should be a greater thing that is part of that education, or broadened to be around public health. It gives you such a perspective even as to why, that colonial impact in that post-colonial world, but that's something that students stop learning at the age of 11 and don't have that worldview. So yeah, I was just wondering how you thought that education could manifest. What do you think that would be in reality?
Okay, so I think I'd like to look at the current blueprint around the climate crisis and how young people are very mobilised by that, and that we could, in some ways, that thread of understanding the impact of emerging infectious diseases could come quite naturally out of that understanding. As I mentioned before, zoonotic diseases are our greatest threat, and so that could be, say, a partnership with that. So starting reasonably early, there's no reason why we can't have public health as part of some kind of core curricula in the same way that we do with other basic educational messages from the age of 11 onwards, or maybe even earlier. It's something that's extremely interesting to young people. It's going to be part of their future. And when I worked with David on the Spanish flu, we were talking quite a bit about antibiotic resistance, for instance. That could be part of that message as well, because obviously viruses don't respond to antibiotics, but a lot of people get a secondary bacterial infection with a nasty viral chest. So we've seen an upsurge in some cases of antibiotic resistance. So just that understanding around what basic epidemiology is and public health actually is.
Great. Yeah, Sophia, did you have your hand up?
Yes, super quick. Actually, I have quite a question, but just super quick on that point. Actually, really interesting. I think someone mentioned in the previous webinars of ours a really brilliant idea about having kind of checklist where you have your 5 fruit a day, have you had your vaccine, and really bringing those other elements that we're missing in terms of prevention into that, what we're thinking in that everyday point, and that also the fact that younger people are thinking about working for longer, being flexible and resilient and going forwards. And I think health could be that part of that conversation. But it's really interesting. I just had a really super quick question about social determinants and inequality, and I guess it just keeps coming up again that we're not investing enough in the social determinants. There is a lot of evidence. I'm not sure how specific in terms of specific interventions, but generally speaking, we know it's important and it's underinvested. I was just wondering, somebody was mentioning in a previous debate we're having about thinking about when we're talking about the cost effectiveness of public health interventions, we often don't compare, say, a smoking intervention with maybe a housing intervention. So, for instance, NICE in the UK wouldn't do that. Is that something that could help? Do we want to do that? And are we kind of underinvesting in those social determinants relative to other public health interventions, or should we just be doing both? But do we have the money for that? So I'm just kind of thinking, how can we shift that forward in these cash-strapped times, really? Any kind of thoughts?
Any thoughts?
Me again. So there's research that provides enough evidence that a smaller amount of investment in social health, for instance, produces a much greater dividend compared to straightforward firefighting healthcare. So from a social determinants point of view, a better understanding of what drives health. Health is an absence of disease, and that's something that public health bodies have been trying to drive for years, but doesn't seem to translate into policy. So you look at things like housing, access to green space, social capital, all of those things are all very central to health, and evidence tells us again that those things are very much lacking in populations from more deprived backgrounds, unfortunately. So it's rethinking how we build our cities, rethinking access to transport, and say one of the core things around social capital and social cohesiveness. So yeah, it's huge. I don't know where we can start, but
Nicola, I totally agree, and I think in fact we could even expand it further, because when people talk about social determinants, it's meant to be social determinants of health, but often they're thinking social determinants of disease, and they're thinking about things that happened early in life and your risk of getting disease later in life. For older people, social determinants of health are also important because they enable people to adapt to or compensate for the conditions and the poor physiologic health that they may have. So disabled access, public transport and things like that enable people still to be able to get where they want to go. So I think also broadening our understanding of what the social determinants are and how they act. That's not just earlier in the life course. It's at any stage of a person's life. They're continuing to have their impact. So I think that would be useful as well.
Great. I think we have time for maybe one more question. Yes.
I was very interested by this debate, and I would like to say that when we are speaking about inequities, we are not only speaking about, we have to think about the links and the complexity between social status, education, health, literacy. And there is this kind of mixture which is very complicated to understand at any age of life. And I think that what is very important is health literacy. What is health literacy? It is to have access to the information, health information, and then to understand the information, and then to assimilate the information, and then to decide to do something, and to trust in the decision itself. So it is a way of doing for taking any decision. But we have first to access the information and to understand it. And I read something a few months ago on UK. In UK, and I don't know if it is true or not, but a third of the population was not able to understand the email message that was sent to them for the COVID pandemics. Is it true or not? I don't know. But when you are thinking about France, there is 2.5 million of illiterate in France. You never think about it. A lot of our patients do not understand what we are telling them. And if we are going ahead, if we like to go ahead to try to have a global approach of human health, animal health, and ecology and ecological health, I think that we have to speak about One Health. And I think that One Health could be a good approach of having more vaccine uptake in our world, and also decrease, indeed, antibiotics for the cattle, and indeed to decrease antibiotic resistance, not only in human but in animals.
Thank you for that. I don't know if anybody else wanted to respond, or we can move to closing remarks. Yeah, David, you wanted?
Yeah, I was just going to come back. I'm probably a bit more with Mark on this. I sort of think we need, and the point earlier around sort of the how much choice do we really want? I think we want to be told. I think that actually, we do lots of work around financial services, and one of the things that's really striking is, seriously, giving someone another leaflet or a video is not going to engage someone with a financial service product. And it strikes me that actually, absolutely, health literacy is extraordinarily important, but actually, frankly, I don't want the choice between 4 vaccines. I want my doctor to say, here's a vaccine, have it. I want my doctor to say, you should do this. I don't want to be given that choice, and I don't actually think it's particularly helpful always. So I think there is that that challenge, but clearly investing in literacy. I lived in Romania for a bit, and early 2000s, and you had pharmacies at that point giving away single antibiotics as change. You had the messages around, drinking this amount of wine is good for you, but that amount is bad. You had really astonishing poor, or actually red wine was good and white wine was bad. I can't remember, but really astonishing sort of poor literacy, which absolutely we have to address. But a bit of it makes me think, actually, I can't possibly understand all the stuff that Nicola knows and John knows. I just want them to tell me what to do.
I think. Oh, sorry. Did you want to just say?
Just very quickly. I'm not sure I know how to articulate this, but some of this discussion, it works very well in developed countries. And so when we're talking about literacy or equality, those are values in themselves. We should not be, and I'm talking about messaging here, we should not give the message, well, people need to be literate so that they understand. I mean, those are messages in themselves. And I think what's important maybe is to align agendas so that when you have a Ministry of Health talking to a Ministry of Education, they're talking about these social determinants. So it's more about how we package the message so that everyone is aware. So I talk to people, and they're not people who are very, very highly skilled, and they're not aware, who are not in public health like you, of the issue of social determinants. So I don't think the messaging should not be around how all these things would work for healthy aging or just for our health, but how do we make policymakers talk to each other so that these issues are addressed in a holistic manner.
Great. There is actually an elephant in the room here, which is the political myth of intergenerational inequity. That, why would we spend money on old people? It's just basically our children's future that we're spending. I mean, there's a whole lot of reasons why that's not true, but I read a really interesting paper the other day which said the real issue is actually intra-generational inequity, and that tends to get passed on to the next generation. So if because of the inequities we have in older age, you have some people who require care and support. They're much more likely to be poor. Their children have to provide the care and support if we don't put in place the systems to do it for them. And so the poverty is passed on. So I think we need to have a very coherent argument against that elephant, because it's sitting there.
Great. All right. Okay, one last question, and then, we'll have to end this session, but please go ahead.
Thank you. That's working. I just have to point out to David that his heretical comments fly in the face of 25 years of efforts to stop medical paternalism. And whilst I totally agree with him, in the real world, there is this belief that it is the right way to proceed to explain to patients what are the choices available to them. And when you start to go down that route, actually I don't think it takes the relationship very far. And I recall my own experiences of my father-in-law with a terminal illness and being asked, my wife and I being asked, which of a series of alternative treatments did we think would be preferential? And we both said, we haven't got a clue. And we're asking you to tell us. And I think that we have to get that balance better between paternalism, which is inappropriate on many, many occasions, and having a realistic insight into what people's understanding is of their health needs. And I think that it comes across many of the things that actually we've been talking about so far this evening. And trying to say that, you know, one vaccine is better than another and is not as good as another, and it doesn't take you anywhere. And all it does actually is further difficulties of people in making choices. And I think we have to grapple with that and perhaps stand back from this paternalism is wrong. And the best actually is to say, I've had this vaccine, if you're a doctor, to a patient or a nurse or any health practitioner, to simply say, I've had it, or my children have had it, and you don't have to go down into the fine print of what. And it's just the example that matters. So,
yeah, no,
you're flying in the face of current thinking, David, but you know, I think you're right.
Been a really great discussion this evening, and so I just wanted to close by saying I'm sure these comments, these points will come again, will be raised again tomorrow, so we can probably have the whole day to really think about this, and even afterwards at the barbecue. But thank you all so much for presenting on your thoughts, really interesting, and yeah, I look forward to speaking with all of you later on in the next couple of days. So thank you.
And thanks, and just from ILC's, you know, a big thanks from me. Just a final apologies for those of you watching virtually, we had a bit of disruption due to a dog who undoubtedly will be hanging around the burgers later. And for those of you watching or in the room, yeah, clearly there's a really fascinating ILC project on pets, isolation, loneliness, older people. So any of you who make vaccines for pets, you know, we're happy to talk to you about that. Good press coverage potential, and great messaging. But as a slide, I just wonder if Lindsay wanted, do we need to say anything about this evening, what the plan is now?
Yes.
Yeah.
Yes. Well, no, but yes.
Okay. But thanks, everyone.
Only that firstly, I'm going to put this on. Click through this for the next people, for the people who are joining us on remotely. This is obviously for them. So yes, as David said, we're having a barbecue this evening. They are already cooking the meat. It smells amazing. For those of you who are meat eaters, of which I am, it's essentially sort of out this room and along that way. So we've got 15 minutes before they're expecting us anyway. 10 minutes.